Hi, thank you for joining this video presentation on Antiretroviral Therapy 2016, focusing on the care of adults and adolescents with HIV. I am John Cohn. I'm an infectious disease internist and professor of medicine at Wayne State University. In today's presentation, recorded August 11th, 2016, we will provide Michigan clinicians an introduction, a practical introduction, we hope, to the use of antiretroviral medications for the health of their patients and for the prevention of HIV transmission. The recommendations in this presentation are based on the current antiretroviral guidelines for adults and adolescents published by the Department of Health and Human Services. The full guidelines, all 188 pages, are available on the website aidsinfo.nah.gov. Also, on that website, you can access an app for your smartphone, which has abbreviated versions of the guidelines and all the tables that are useful. It's a very useful item if you're going to be doing antiretroviral treatment. And then the last slide of this presentation will give you some additional resources for Michigan providers to get expert advice on HIV treatment and antiretroviral use. So all integrated HIV prevention starts with the diagnosis of HIV infection and then moves to the use of antiretrovirals either in persons with HIV on the left or even in persons without HIV but at risk on the right. In this slide set, we will discuss the use of antiretroviral therapy in persons who have HIV, emphasizing how to use them to protect the health of your patient, and coincidentally, by reducing their viral load, you will make that person less infectious and reduce future transmission. More detail on use of antiretrovirals for prevention, both treating your patient and treating uninfected patients with PEP and PrEP, are discussed in the companion slide set, also available on this website. For these things to be effective, either treatment or prevention, it requires the combination of biomedical services and psychosocial services. The biomedical services can be HIV testing, antiretrovirals for treatment and prevention, and the HIV primary care. On the other hand, for these to be accessible to your patients, for them to make use of these interventions, there may be barriers, social barriers, financial barriers, behavioral health conditions that need treatment. They may need to overcome feelings of stigma and discrimination for themselves, for their family or partners. So psychosocial support is often very important to make treatment or prevention interventions successful. So focusing here on antiretroviral medications for treatment, I remind you that the extraordinary reduction in HIV-related mortality over the last 20 years is a result directly of effective antiretroviral treatment, and that nowadays in the U.S. and developed countries, most deaths among HIV-infected persons are due to comorbidities rather than HIV itself. So liver disease such as hepatitis C, although of course now hepatitis C itself is curable, cardiovascular disease, heart attack, stroke, and so forth, and non-AIDS related malignancies. Most of my HIV patients who died in the last 2 years died of lung cancer rather than an AIDS-related malignancy or infection. HIV itself is either proven or thought to increase the risk of progression or decrease the age of onset of these non-HIV conditions. For example, liver disease from Hep C progresses faster in people with HIV than people without HIV. It's thought that cardiovascular events and non-AIDS-related malignancies are occurring perhaps 10 years earlier than they would in the general population among people with HIV infection. And it is thought that the chronic immune activation occurring in people with HIV is part of the cause of this early onset of non-HIV specific diseases that still impact morbidity and mortality. This chronic inflammation is improved with antiretroviral therapy, but is not completely stopped by antiretroviral therapy. So the next phase of treatment and research into treatment for HIV will be how to control that chronic inflammation or chronic immune activation once the virus is completely controlled. For today, we're focusing on controlling the virus with the currently available medications. Antiretroviral therapy is currently recommended for all HIV-infected individuals, regardless of CD4 cell count, to reduce the morbidity and mortality associated with HIV infection. Early in antiretroviral therapy, the drugs were toxic, had to be taken very often, were not that potent, and had a high failure rate. So treatment was targeted to only those people who had advanced disease and for whom the benefits outweighed the risks and toxicity. Gradually, the medications have improved, and the series of randomized controlled trials have shown that a broader and broader range of persons living with HIV get clinical benefit from antiretroviral therapy. So currently, based on randomized controlled trial I will show you in a moment, all adults with HIV infection have been proven to benefit from antiretroviral therapy. These data are not complete for people with acute HIV infection, people who have just caught HIV, but we intend to treat them as well. And there's a little uncertainty for persons who are elite controllers, that is, persons whose viral load is undetectable even without taking antiretroviral therapy, though there's some data that these people can benefit from treatment as well. This information is also extrapolated to adolescents, for whom we don't have complete randomized controlled data, and to youth. In addition, antiretroviral therapy is recommended for all HIV-infected individuals to prevent HIV transmission. We have randomized controlled data to prove that antiretroviral treatment reduces, almost completely prevents perinatal HIV transmission, reduces and almost completely prevents heterosexual transmission, and these data are extrapolated to sexual transmission among men having sex with men and to persons, drug injectors sharing needles. So the benefits are assumed to be true across all persons with HIV. So the drugs are great, but patients must be educated and supported to maintain excellent adherence with these medications. And rarely you may postpone starting treatment when there are immediate barriers to adherence that you have to address before the person is going to succeed with treatment. This is the randomized controlled study that led to the current recommendation of giving antiretroviral therapy to all persons with HIV. Cleverly, this was called the START study. It randomized persons who had a CD4 count over 500, so almost normal, to either starting antiretroviral therapy immediately or waiting until the CD4 count fell to 350 and to start antiretrovirals at that point. 4,685 patients in 35 countries were randomized and followed for a mean of 3 years. Some people were in the study longer, 4 or 5 years. Patients achieved viral suppression of less than 200 copies per mil shortly after starting antiretroviral therapy in both groups. On the tables on the right, the lines in red show the events in people who started antiretroviral therapy immediately, and the events in blue show the people who had delayed starts of antiretroviral therapy, waiting for the CD4 count to fall. The top panel shows from 0 going up to over 90% viral suppression in the first really weeks of the study, as the first group started antiretroviral therapy immediately and shut down the virus at a very high rate and maintained that viral suppression up to 5 years of follow-up in the study. The blue line shows the gradual suppression of viral loads as people gradually started antiretrovirals in the postponed group because they gradually started antiretroviral therapy as the CD4 counts fell. So the randomization worked. The bottom part of the graph shows the changes in CD4 count in the two groups. The red line shows the CD4 counts improving immediately at the start of the study among the people who started antiretroviral therapy immediately. And the blue line shows an initial decline in the persons who postponed antiretroviral therapy. As we would expect, they are waiting for their CD4 count to fall before they started antiretrovirals. So these two plots really show how effective the randomization was and how effective the antiretroviral therapy was once it was started. Okay. Now we turn to the results of the START study. There are many tables on the next slide showing the results, so we put the explanation of the different panels on this first slide. We'll focus on panel A and panel E. Panel A shows the composite primary endpoints, which is the combination of a serious AIDS-related event or a serious non-AIDS-related event or death occurring in a person randomized to this trial. And there was over a 50% reduction in events in people who started antiretroviral therapy early compared to those who postponed the antiretroviral therapy till the CD4 count fell to 350. Panel E shows serious, potentially life-threatening toxicity in both groups. Here are the tables with the results. The top table shows panel A, the serious AIDS, non-AIDS events and deaths in the two groups. The red line demonstrates the low rate of these events occurring in people who started antiretroviral therapy immediately, and the blue line shows the higher rate of these events occurring over time among the people whose antiretroviral therapy was postponed till their CD4 count had fallen to 350. And the difference between these two lines is that greater than 50% reduction in events, therefore representing the clinical benefit to the patients in starting antiretroviral therapy at the higher CD4 counts, over 500. The bottom right panel shows the toxicity issues. You'll see here the red and blue lines perfectly overlap, which is to say there was no increase or measurable serious toxicity among people who started antiretroviral therapy early compared to those who postponed treatment. So this shows that both there's a clinical benefit to the patients with early treatment and that there's no increased toxicity by starting early. One more issue about starting antiretroviral therapy, on the other end of the spectrum, looking at persons who have advanced disease, randomized controlled data show that there's also a 50% improved survival if antiretroviral therapy is started within a few weeks of a newly diagnosed and treated opportunistic infection. So as opposed to the first study, which looked at people who were healthy and had high CD4 counts, here we're looking at people who are hospitalized with an acute opportunistic infection, generally with quite low CD4 counts, but with newly diagnosed HIV in this setting. And as I'll show you in the next slide, there was a 50% reduction in mortality if antiretroviral therapy was started within 2 weeks rather than within 6 weeks. That 1 month difference in treatment translated to a 50% improved survival rate at 1 year. Kind of extraordinary that a small difference in how quickly you started antiretroviral therapy made such a big difference in mortality. There are a couple of caveats to this. There are a couple of situations where early antiretroviral therapy in acute opportunistic infection can be dangerous. One of them is cryptococcal meningitis, where too early treatment can increase the death rate, and TB, especially TB meningitis, where too early antiretroviral therapy may increase the death rate. This is thought to have to do with inflammation in the brain that occurs early in antiretroviral therapy when someone has an active opportunistic infection of the brain, like cryptococcal meningitis, like TB meningitis. But other than these two circumstances, the sooner someone with an opportunistic infection can successfully get on antiretroviral therapy, the better their mortality. This shows those results. The left-hand panel on the top shows how quickly people got on antiretroviral therapy. The solid line showed the very rapid. This slide is upside down compared to the others. It's just how the studies were published. The drop in the line on the left, the solid line, shows from 0 to 100% how quickly people in the early treatment arm got onto antiretroviral therapy. So most were on within a couple of weeks of treatment. And the dotted line shows the more gradual onset of antiretroviral treatment among people with opportunistic infections who had a delayed, more usual onset of antiretroviral therapy. The table on the right shows the difference in mortality. The solid line shows the reduced mortality, the improved survival rate among people who started antiretroviral therapy early in the setting of an opportunistic infection, and the dotted line shows the doubling of mortality among people who had even a month or two postponed antiretroviral therapy in the setting of opportunistic infection. So we really tried to start therapy very quickly in this setting, but still it's challenging to make sure there's a way for paying for medicines, making sure the person will be adherent. So it's our goal to do this, but it has challenges. Turning to the drugs themselves, there are currently 6 types of antiretroviral therapy using 6 different mechanisms. We won't talk about them all today. Today we will talk about nucleoside analog reverse transcriptase inhibitors, shown in the orange box on the top. This was the first category of antiretroviral therapy. The first drugs were in this, use this mechanism. As you will remember, HIV is an RNA virus and has a reverse transcriptase enzyme to convert single-stranded RNA to double-stranded DNA. These nucleoside reverse transcriptase inhibitors block that reverse transcriptase enzyme and reduce HIV growth. We will talk also about integrase inhibitors in the blue. This is the newest category or mechanism of antiretroviral therapy. Integrase enzyme brings the double-stranded DNA that was just produced across the nuclear membrane and inserts it into the genome of the host cell. It's really an integrase strand transfer step. And we have a series of most modern drugs called integrase strand transfer inhibitors that block that step. Without that integration of double-stranded DNA into the host cell genome, there is no long-term infection of host cells, and the virus cannot replicate. The other category we'll discuss today are the protease inhibitors in the red color on the bottom right. These were developed in the late 1990s initially. These are very potent drugs. They block HIV protease, an enzyme that converts long HIV polypeptides into short functional structural proteins and enzymes. When that protease enzyme of HIV is inhibited, virus particles are produced, but they're defective. They don't have the right structure. They don't have the right enzymes. They're not infectious, and infection slowly dies out. This slide shows the 27 currently licensed antiretroviral agents. When we show this to the ID fellows, their eyes pop out. I've been doing HIV care for 33 years, so I've only had to learn about 1 a year, slightly less. So it's not been so bad for me. To learn these all in an hour is kind of silly. But we will introduce you here today to the most important of these. The ones listed in green are the medications that are on the first-line recommended treatments in the DHHS guidelines, and we will focus on these and show you patterns about how they work so that you can have a handle on remembering them. You'll see that we have NRTI and nucleoside reverse transcriptase drugs that are important. We have integrase strand transfer inhibitors that are important. A couple of the protease inhibitors are used as first-line treatment. I also show 2 pharmacologic boosters. I'll explain about that in a moment. One of these is an antiretroviral drug, Norvir or ritonavir, so it's listed both as a protease inhibitor and in this category. And one of those boosters, Tyboost or cobicistat, has no effect on the virus itself. It's only used to affect other medications and improve their efficacy. On this slide, I show 3 different names for almost every drug. They start with the brand name. So if you look at the upper left panel, you'll see Viriad, which is the brand name of a medication. Then in parentheses, you'll see the generic name, tenofovir DF, or tenofovir disoproxyl fumarate. We'll see that spelled out in a few moments. And you'll see the accepted 3-letter abbreviation for it, TDF. These, not only is it confusing to have 27 medicines, it's confusing when each one of them has 3 names, and then when there's combinations of these with other names. So for most of this presentation, I will focus on the brand name to be consistent, but you will read these other words if you're reading about HIV care. The guidelines are mostly written with generic names, so I show these to you more for a reference if that's helpful to you. So current antiretroviral therapy, sometimes called HART, or highly active antiretroviral therapy, or CART, combination antiretroviral therapy, involves 3 or more drugs. And these are usually 2 nucleoside analog reverse transcriptase inhibitors, as what is often called a nuke backbone. And they are paired with 1 strong drug, which is often nowadays an integrase strand transfer inhibitor, which may be boosted with a 4th drug. They may be paired with a protease inhibitor, which is often boosted with a 4th drug. And less commonly, and not so much for discussion today, a non-nucleoside reverse transcriptase inhibitor. So to focus on the boosting for a moment, many of the medications that are used for HIV are broken down in the body by the cytochrome P450 system, and especially the CYP3A4 enzyme system. Many medications we give people are metabolized by this same system. By inhibiting that enzyme, you can raise the levels of medications that are being used. So this is done on purpose with certain HIV medications. By boosting the antiretroviral, by blocking the CYP3A4, you can increase the half-life of a drug. That increases the trough concentration of drug. And for some of the drugs, you can increase their peak concentration. Doing this will usually reduce the risk of drug resistance against that medication, will often improve dosing requirements. For instance, there are some medicines that have to be twice a day unboosted, but are once a day boosted. But the trouble is these can cause complex drug interactions with other antiretroviral drugs and with many other medications. And so when you have a booster in the mix, it's imperative that you look up drug interactions. They differ even between Norvir and Tyboost. So you have to look for the specific booster and the other medications your patient is taking and make sure everything is dosed properly. We'll talk more about this in a few moments. Again, the 2 boosters, one is Tyboost or cobicistat. It's not an antiretroviral. I'll show you that it comes packaged in 2 of the combination pills to boost an integrase inhibitor. So it's a once-a-day medication. Tyboost or cobicistat raises serum creatinine without affecting kidney function, and it's not recommended for persons whose creatinine clearance is under 30. Norvir or ritonavir started life as an antiretroviral drug. It was actually the 2nd protease inhibitor that was licensed. At that time, it was given 600 milligrams twice a day. It was extremely effective, but very toxic. But it is a CYP3A4 inhibitor, and now we use it exclusively to boost other antiretroviral drugs, usually other protease inhibitors, at much lower doses. So 100 milligrams once a day, up to 200 milligrams twice a day. I point out the difference in dosing because now and then a well-intentioned person means to use Norvir boosting, looks up the dose online somewhere, and gives 600 milligrams twice a day, which is absolutely not the dose for boosting. The dose for boosting is much less, as I show you here. Norvir has some GI side effects and possible hepatotoxicity, so there are downsides to using it, although we rarely nowadays give a protease inhibitor without boosting it by Norvir. So here's a table showing the 9 recommended first-line regimens in the DHHS guidelines. We will go over these again in a few moments, but I want to show you a few patterns. First, let me remind you that these first-line regimens are intended for someone who has never been treated before and has no drug resistance, because that changes the choices drastically. So along the left side of this panel are the brand names of the individual or several tablets that go into these regimens. The second column and third column, first NRI and second NRTI, these show the nuke backbone that is part of each of those 9 regimens. The next two columns show the strong drug, and the current recommended first-line regimens all either involve an integrase strand transfer inhibitor, as you see, and a couple of them involve a protease inhibitor. There's no NRTIs here on the first-line recommended medications in these guidelines. Some of the medications require boosting, so you'll see in the right-hand column cobicistat or Tyboost listed for a couple of these medications, that the elvitegravir that requires boosting, and you'll see ritonavir or Norvir to boost the protease inhibitor. As I mentioned, we rarely give protease inhibitors without boosting, and actually darunavir or Prezista is not even licensed to be used without boosting. You'll notice that the first line shows abacavir lamivudine as the nucleoside backbone, and you'll see that all the other nucleoside backbone options are variations on tenofovir with emtricitabine. We'll look at this more closely, but I'd like you to see this pattern of the drugs that are the first-line recommendations. So for the most commonly used nuke backbone, we have the combination often called Truvada. It's the two drugs I was just pointing out. The original version of tenofovir, also called tenofovir disoproxil fumarate. That drug by itself has a brand name Viriad and is usually abbreviated TDF. It's paired with emtricitabine, which oddly has the abbreviation FTC and more reasonably has the brand name Emtriva. When these two drugs are in one pill, that combination pill is called Truvada, and these two drugs are in some other combination pills with other names, as I'll show you. So tenofovir is a very potent and very safe nucleoside reverse transcriptase inhibitor. It has some potential toxicity, nausea, vomiting, flatulence, headache, as I show you, but these are uncommon. Its main trouble is nephrotoxicity, and it's not recommended for persons whose GFR is under 60 because it can contribute to renal failure. One of the ways it contributes to renal failure is causing proximal tubule dysfunction or Fanconi's syndrome, which means the kidney loses phosphorus, glucose, protein, a whole host of other chemicals are leaked out of the proximal tubule. That leak of phosphate from the proximal tubule means that the body reabsorbs bone to make up for the phosphate loss, and that causes bone demineralization also. So this is the Achilles heel, if you will, of tenofovir DF. One mutation, K65, causes resistance to tenofovir and to most NRTIs. This drug happens to be also very potent and licensed for hepatitis B. It's probably the best currently licensed hepatitis B drug and is concurrently used for HIV. So it's very convenient to use this when treating someone who has HIV and hepatitis B at the same time. There is the risk of hepatitis B getting worse if someone suddenly stops any hepatitis B drug. That risk might be higher with this tenofovir because it's the best hepatitis B drug. Hep B is more strongly suppressed by it, and when the drug stops, the hepatitis B can more dramatically rebound. So one has to be very careful using this medicine in people with hepatitis B. It's a great benefit, but you have to be quite careful. It does have some drug interactions with hepatitis C meds via a different mechanism, P-glycoprotein. So sometimes we avoid this drug when we're giving certain of the hepatitis C medicines. As I said, this is almost always paired with Emtriva, emtricitabine or FTC. It's a very low toxicity drug. It sometimes causes skin or nail pigmentation. One mutation causes high level resistance to this and also to lamivudine, which I'll show you on the next slide. This is also active against hepatitis B, but is not licensed for that. But the same issues about starting and stopping this drug in someone with hepatitis B apply as they do to tenofovir. Usually you're using them together anyhow. Emtriva or emtricitabine needs a dose adjustment when the kidney function, the GFR, is under 30 mils per minute. This medicine, by the way, Truvada, is also the medicine that's used for pre-exposure prophylaxis. So if you're doing PrEP rather than antiretroviral treatment, you still want to be very familiar with this combination. So there's a new version of tenofovir called tenofovir alafenamide, or TAF. It's a new prodrug of the same antiviral tenofovir. It's more completely absorbed. It means the oral dose is lower and that there's a much shorter serum half-life of the active drug. The tenofovir alafenamide is rapidly taken up into lymphocytes and monocytes, and the active tenofovir winds up in a higher concentration in the cells where it's needed. At the same time, there's a lower concentration in the kidney cells where it has toxicity. So this is a big advantage. It is active in vitro against hepatitis B. It is not yet licensed for hepatitis B, but I believe it's at the FDA for that. And sometimes we hedge a little bit and use it in an HIV Hep B co-infected person. This is not licensed for PrEP, and the manufacturer plans a large randomized trial to see if this version of tenofovir will be effective as PrEP. We are still sticking with Truvada for the meantime. Although this is less nephrotoxic than the original version of tenofovir, TDF, it's still not recommended for a GFR less than 30, and there are some important different drug interactions. For instance, you can't use this with rifamycins, rifampin, for example. In clinical trials of 1 to 2 years duration, there is less effect on creatinine clearance and less decrease in bone mineral density on persons taking TAF compared to the original tenofovir TDF. So there's clinical evidence of lower toxicity. Not necessarily zero toxicity, but less toxicity than the original tenofovir. And TAF now exists as part of 3 different combination pills. It is not licensed yet by itself, which is why there is no brand name for it on this slide, but it is part of 3 other combination pills. Genvoya in green and Descovy in green are 2 of the 3 recommended regimens. That's why I put them in green. We'll see them again in a few minutes. Odefsey is kind of the is TAF. It's not a recommended combination pill, but it is a combination pill that substitutes TAF for a TDF. We won't talk too much about it because it's not on the top picks in the DHHS guidelines. So the other nucleoside backbone, the one in the first line with Triamec, is a combination of abacavir or Zygen, abbreviated ABC, with lamivudine or Epavir, abbreviated 3TC. These drugs come together as a tablet called Epzicom, and they come together with dolutegravir in the tablet called Triomec, which is the one we'll really be talking about when we look at drug regimens. So abacavir is quite strong on the virus. It's quite effective, but it has a couple of issues. There is a hypersensitivity syndrome, which occurs 6 weeks to 3 months after starting in certain people. It causes fever, a rash, and respiratory or GI symptoms. It gradually worsens as a person continues to take abacavir. If a person stops the drug, those symptoms improve, and if they are rechallenged, they can become terribly sick, and there have been deaths on rechallenge with abacavir of persons who have had hypersensitivity syndrome. And some of those people collapsed and died within hours of taking a tablet of Zygen after recovering from a first episode of hypersensitivity. This can be essentially completely avoided by testing someone in advance for the HLA-B5701 allele. Almost only people with this allele are susceptible to the hypersensitivity syndrome, and if the person tests negative, you can be nearly perfectly assured that the hypersensitivity syndrome won't happen. So our standard of care is we never give this drug without the HLA-B5701 test being done and having the result. I want to warn you that this is HLA-B5701. We're not looking for ankylosing spondylitis. It's not HLA-B27. It takes something extra sometimes to really order the correct test. I think every laboratory in Michigan can access this test, but you have to be careful that you're ordering the right thing, because I have seen the wrong HLA test ordered, and then abacavir might be given to someone who is at risk for hypersensitivity. Another concern about abacavir is that there is a possibility of a small but increased risk of myocardial infarction. This was not seen in any of the randomized controlled trials with abacavir, but it was seen consistently on observational data sets of very large numbers of people getting treated, like tens of thousands of people getting treated. And there is timing where the risk of a heart attack went up within 6 months of starting abacavir, and the risk went down within 6 months of stopping abacavir. The FDA reviewed this. They didn't find any evidence of risk in all the randomized trials, and so they said if there is a risk, it must be small. The DHHS guidelines say, well, it might be small, but it might be real. I take that risk seriously when I'm choosing medications. Advantages of abacavir is there's no nephrotoxicity, so it can be used without dose adjustment regardless of renal function. Lamivudine is like emtricitabine. It's very well tolerated. It has the same mutational resistance, so they're cross-resistant. It is also an HBV hepatitis B drug. It's actually licensed for Hep B, but resistance emerges very quickly when lamivudine by itself is used to treat hepatitis B, especially in co-infected patients. So you would never use this abacavir-lamivudine combination to treat hepatitis B in someone with HIV. The same issue of suddenly stopping lamivudine in someone with Hep B is true as with the prior drug, but again, you wouldn't purposely be giving this to someone with hepatitis B. Lamivudine needs a dose adjustment when the GFR is under 30. So the Integrase Strand transfer inhibitors, there's 2 generations of these. These are the most commonly used strong drugs in the DHHS guidelines. The first one licensed is called Isentress, or generic raltegravir. It's a very good and potent and rapidly acting drug. It's twice daily, and people are not that thrilled about twice daily medicines now, since so many can be once daily. It needs a dose adjustment with rifampin. It has cross-resistance with the other first-generation integrase strand transfer inhibitor, also shown on this slide. And resistance can happen fairly easily. It does not have a very high barrier to resistance. But other than rifampin, it has very few drug interactions. It works very easily with all the hepatitis C medicines, for example. So it still has a role. We also use it in post-exposure prophylaxis because it works very fast and is very well tolerated, despite being twice a day. The other first-generation integrase strand transfer inhibitor is called Vitecta, or elvitegravir. It is rarely prescribed as Vitecta, but is usually prescribed as part of a combination pill, as Stribild or Genvoya, and we'll look at those combination pills again in a few moments. This medicine, in order to make it a once-a-day drug, is always boosted. When it comes in Stribild or Genvoya, there's 150 milligrams of Vitecta mixed with 150 milligrams of Tyboost or Cobicistat as the booster. If you're giving Vitecta outside of that combination pill, you have to have some other way of boosting it. I show here ways it can be used with ritonavir or Norvir plus boosted protease inhibitors. It gets a little complicated. There's 2 different dosage forms of Vitecta, 150 milligrams and 85 milligrams. And depending on which protease inhibitor you're pairing it with, you use different doses of Norvir boosting. So you just have to look this up if you're going to do it. It's not used very widely, but it is an option for some patients. As far as first-line regimens go, Vitecta elvitegravir only appears in the Stribild or Genvoya single-tablet regimens. There can be some nausea or diarrhea with this drug. It's cross-resistant with Isentress or raltegravir, as I just mentioned, and resistance mutations to either of these drugs can reduce the effectiveness of the second-generation integrase strand transfer inhibitor, which is Tivicay, or dolutegravir. So this is the newest among the integrase strand transfer inhibitors. It's the most potent. It has the highest barrier to resistance. It's intrinsically once a day. It does not require boosting, so it's just 50 milligrams once a day if there's no integrase resistance. If there is some resistance or some early integrase mutations, it's dosed twice a day, and for some drug interactions, it's dosed twice a day. But usually it's once. Because it doesn't have to be boosted, there's a much lower issue about drug interactions than with Vytecta or elvitegravir. Hypersensitivity is reported with this, but it's not the same as abacavir. It's much less frequent. It's not necessarily as serious. There's no testing to do in advance to screen for it. Some people get insomnia or headache, but it's usually thought to be a very well-tolerated medicine. It has a fairly high barrier to drug resistance, and usually multiple mutations are required for drug resistance to develop against Tivicay. And so far, there's a very low rate of drug resistance to Tivicay among people who are prescribed it if they start with no integrase resistance. So people are very hopeful that this will be a very good drug, even if people are not extremely adherent with their medication. I still hold out a little bit of uncertainty with this, but we'll talk about that again in a few moments. The last category of medication that exists in the first-line regimens are protease inhibitors. The one that's really listed as a first-line drug is Prezista, also known as darunavir. There is a combination pill of Prezista with a built-in booster, tibustacobacistat, called Prescobix. That Prescobix is not in the guideline as a first-line regimen. So I listed it here to be complete and giving you all the names of these things, but we're not really going to talk about Prescobix. We'll talk about Prezista boosted by Norvir. And in someone who's starting treatment for the first time, they take one red 800 milligram Prezista tablet with a 100 milligram Norvir tablet for boosting. But one of the uses of this might be in pregnancy, and the dose is increased in pregnancy to twice daily. But it's 600 milligrams of Prezista twice daily with 100 of Norvir. So people do get mixed up between the 800 and 600 tablet when it's once a day or twice a day. Patients get mixed up, prescribers get mixed up, pharmacists get mixed up. So you have to be rather careful that you're getting the right dose of the Prezista tablet. Normally, a non-pregnant person starting treatment would get 800 milligrams once daily with 100 of Norvir. Prezista is always boosted. It's never been developed or really studied in clinical trials as an unboosted drug without Norvir. This is the best tolerated protease inhibitor, although some people could get a skin rash, GI toxicity, and like all protease inhibitors, it can have lipid effects. It can cause insulin resistance or contribute to insulin resistance. It might contribute to lipodystrophy, might contribute to hepatotoxicity. So it's not a low toxicity drug, but it's very potent and best tolerated among the protease inhibitors. It's the only protease inhibitor that's generally considered for first-line use. It's very potent. It has a very high genetic barrier to resistance. So it takes many mutations for a virus to develop resistance against Prezista. It's very rare for a virus resistant to Prezista to circulate. Somebody catching HIV for the first time, even if they catch drug-resistant HIV, it's almost certainly going to be susceptible to Prezista. It would be very rare for that not to be true. The other thing about the boosted protease inhibitors is not only do they have a low rate of developing resistance, but they protect the nucleoside backbone. And this is something we don't know about dolutegravir or Tivicay. Tivicay seems to protect itself, but we don't know if it protects itself as well as the protease inhibitors, and we don't know if it protects the nucleoside backbone as well as the boosted protease inhibitors. So to me, these boosted PIs are very useful drugs when we're worried about drug adherence or pre-existing resistance before genotypes come back. I show you also Reataz or atazanavir. This is not on the list of first-line drugs in the DHHS guideline except in pregnancy, and so I included here just for that purpose. It's recommended in pregnancy as first-line, but otherwise is not first-line. It's given in pregnancy as 300 milligrams once daily. There's a 300 milligram capsule, again with 100 milligrams of Norvir and the nucleoside backbone. And I include it here because although Prezista can be given in pregnancy too, That becomes twice daily, and Reataz is the only protease that's once daily in pregnancy. It does have interactions with antacid therapy, PPIs, and H2 blockers, so there's some issues about dosing and timing of medications if someone is taking ranitidine or a proton pump inhibitor. A common toxicity is that it inhibits glucuronal transferase, so it raises the unconjugated bilirubin. This is not really toxicity. It's not hepatic disease, but it's common for people on this drug to have bilirubins of 2 and 3. Oddly, we give it in pregnancy, and so far there's been no issue about kernicterus in the newborn, where otherwise we go crazy about avoiding bilirubin elevations in late pregnancy, but this has been used safely in that setting. This has very minor lipid effects compared to other protease inhibitors. It can cause kidney stones. It can cause gallbladder stones. It has some nephrotoxicity itself. It can cause PR prolongation. And like other protease inhibitors, there's insulin resistance, lipodystrophy, hepatotoxicity. And unlike Resista, a single mutation can cause resistance. So this is not as safe in terms of avoiding resistance as boosted Resista, but for pregnancy, it's the only once daily protease inhibitor. Got that? So here we see again that table that we saw a little while ago with the 9 first-line regimens that are recommended in the DHHS guideline. And now you know perhaps a little bit more about each of the words in these columns. I'm going to talk about 4 choices here. Triomec, Stribild, and Genvoya. You see these are labeled STR, which means single tablet regimen. That means that all the medications for HIV are in the one tablet. 3 or 4 drugs are in the one tablet, and the single tablet regimens are very popular. And then I'm going to talk about Resista with Norvir, the Norvir boosted protease inhibitor, for a couple of specialized circumstances, even though that's 3 pills a day instead of 1. So Triomec, remember, was Abacavir or Zyagin with lamivudine or Epivir, and dolutegravir or Tivicay. Remember, Tivicay or dolutegravir is the newest, strongest, second-generation Integrase strand transfer inhibitor. Very potent, high barrier to resistance, few drug interactions, well-tolerated, no boosting, fast-acting, a really great drug, but here it's paired with Abacavir and lamivudine. Remember, you will never give Abacavir without testing first for HLA-B5701, and if someone tests positive, you're just not using it. Also, Abacavir has this issue of potentially increasing the rate of heart attacks. I myself just don't use it if someone is on a statin and aspirin, has existing atherosclerotic disease, and I'm very wary in people who have diabetes and hypertension and hyperlipidemia and smoke. Of course, as the primary care provider, you're very busy improving all those risk factors, but even so, I'm reluctant to use Abacavir in those patients. And finally, you would not use it in someone with hepatitis B because it's only 1 weak hepatitis B drug, lamivudine. On the other hand, this is great for people with hepatitis C because it's compatible with all of the hepatitis C medications. So this is a very popular single tablet regimen, as long as you do the prior testing and you're careful about who gets it. Genvoya and Stribild are very similar. If you look across the line, the only difference is which version of tenofovir is in it. Stribild was the first of these quad pills with the original tenofovir DF. Genvoya is the newer version with tenofovir alafenamide or TAF. Otherwise, they're the same. These drugs are very effective. They are fast-acting. They are safe in someone with HLA-B5701. They are good for someone with hepatitis B, although TDF is the drug that's licensed for hepatitis B in Stribild, and TAF is still not yet totally proven in hepatitis B, as in Genvoya, but it is probably effective as well. These drugs have that booster, cobicistat or Tyboost, to make the elbaptegravir last all day, so there's more drug interactions. But these are very useful and frequently used single-tablet regimens. So the modern competition for single tablet regimens is more or less between Genvoya, the new TAF quad pill, and Triomec. And really, both are fine. There's just a few reasons you might prefer one or the other. Looking at the Norvir-boosted Truvada, as I mentioned, Norvir-boosted Truvada is almost always active, even if there's some pre-existing drug resistance, even if there's some pre-existing protease inhibitor resistance. It has a very high barrier to resistance. I mean, boosted protease inhibitors for more than a dozen years have an excellent track record of avoiding drug resistance, even in people who are very inconsistent at using the medicine. And they also protect the companion nucleoside backbone. So when I have someone I'm unsure of their adherence, I tend to use this. This is contrary to what many people like to do. They say if you're not going to take your medicine well, better to give you one pill than three. I take the opposite view. I think if you're not going to take the medicine well, better to take something where resistance is almost certainly not going to go wrong no matter what you do, as opposed to someone where there's a higher risk of drug resistance. So you have to decide what concept you prefer. These are all considered first-line regimens. DHHS gives you the choice. As I say, my preference is the boosted protease when I'm uncertain about adherence. So teenagers, I prefer boosted protease. Alcoholics, drug users, sometimes people with major mental health problems where I'm just not sure they're going to take their meds. It's my guess. I may be guessing wrong. And I'm very willing to switch from a boosted protease to a single tablet regimen if someone establishes that they are reliable and effective in taking their medication every day. There's more choices on this slide than I've mentioned, and there are more choices that are alternatives to these first-line regimens. So there's really, really many choices. And if you're not sure, make the phone call. As we'll show you at the last slide, there's many people ready to pick up the phone and guide you through these choices so you make the best choice individualized for your patient. Reminding you about pregnancy, the regimens are slightly different. As I mentioned in the other presentation, the Michigan standard is that everyone who's pregnant gets at least 2 and sometimes 3 HIV tests during pregnancy. The first HIV test is at the diagnosis of pregnancy. The second test is at the beginning of the 3rd trimester. And the third test in someone who's high risk would be close to delivery or in labor with a rapid test to make sure the person is not infected and no intervention is required to protect the mother and baby. The DHHS guidelines emphasize that prompt diagnosis and immediate antiretroviral therapy is very important because you want to get the virus controlled before the baby or fetus acquires HIV infection. So all delays are out the window, and we do the fastest thing we can to get them on treatment in the safest way we can. And it's really good to get expert advice if you've not been doing antiretroviral therapy or treating pregnant women with antiretrovirals before. You'll see for the dual nucleoside backbone, some of the choices we've had already, Truvada or Epzicom. Epzicom with that HLA-B5701 test, of course, required before you give the abacavir. We don't have Descovy, the TAF version of Truvada up here. It's newly licensed and not made its way into the pregnancy guidelines. It may prove to be perfectly safe and be a good substitute, but it just happens not to be in these yet as being recently licensed. We haven't talked about Combivir, the original drugs used for preventing perinatal transmission. They have more toxicity. They're twice daily, and we don't use them often nowadays. I showed you the 2 choices for a boosted protease inhibitor as the strong component of a regimen for pregnancy. I recommended Reataz and Norvir because of the once-a-day dosing, even during pregnancy. Truvada and Norvir is also very good, but in pregnancy it's twice daily. And remember the 600 milligram versus 800 milligram dosing of Truvada, depending on whether it's twice daily in pregnancy or once daily in other patients. Icentrus can be used, but there's much less information about it in pregnancy, so it's not usually a top choice so far, and it's also twice daily. And although we didn't discuss it much, the NRTI, non-nucleoside reverse transcriptase inhibitor Sostiva, is still on the list. This is a drug that causes anencephaly in primates so I have really tried to avoid it. The theory is that the risk only occurs before 8 weeks of gestation, and after 8 weeks, the risk is gone, and so you could use this. Sostiva is used a lot worldwide, where these other drugs that we've been talking about, the boosted protease inhibitors and integrase inhibitors, are not very available. But I would say in the U.S., although it's still on the list, we have other probably safer and better tolerated drugs to be used in pregnancy as the strong component of the regimen. Boosted Reataz, boosted Pruzista, even twice daily Icentrus are likely to be better tolerated than Sostiva. Always paired with Truvada or Epzicom. Oh, I should also mention that if someone becomes pregnant when they're on an effective regimen, you don't have to change them. If they're doing well, the virus is suppressed, and they're not having any toxicity, they can continue to take their regimen. And even if it was Sostiva, the guidelines say by the time you've diagnosed their pregnancy, you're probably past 8 weeks, and the risk has already happened if it's present. It's another reason to avoid Sostiva in women who could potentially become pregnant. But ordinarily, we don't have to change an effective regimen in a woman who becomes pregnant. These guidelines are really for regimens to start when HIV is diagnosed in pregnancy. Here I remind you of the 6 licensed single-tablet regimens that are available in the United States, half of which are on the top first-line regimen recommendations. Triamec we discussed, Genvoya we discussed, Stribild we discussed. They're in those tables we've looked at. There are 3 others, Odefsey, Complera, Atripla. They're licensed drugs. They work. They each have problems with them. They're considered alternatives. Because we have limited time, I'm not going to discuss them, but you could read more about them in the DHHS guidelines, and there are some times where one or another of these would be appropriate for a patient rather than the ones that are in green. You have to be very careful about drug and food interactions with all of these medicines. Statins, anticonvulsants, cardiac medicines have many interactions with antiretrovirals. Some of them are potentially dangerous. Acid-reducing therapies may reduce the absorption of some of these medicines. Calcium, magnesium, aluminum, iron, zinc taken at the same time might prevent the absorption of the integrase strand transfer inhibitors, and they must be taken at separate times. Hormonal contraceptives are not good combinations with almost any antiretroviral therapy. Really, among the 6 top choices, only Triamec is a good choice. Rifamycins interact, like rifampin, with almost everything, so you have to choose the right drug and choose the right dose. With hepatitis C, direct-acting antivirals, there's many two-way drug interactions, and the DHHS guidelines have a separate table with all the hep C drugs and all the HIV drugs to tell you which things you can combine and which you should avoid. Food is needed when you're taking almost every antiretroviral regimen except for valtegravir, which is Icentrus, or dolutegravir, which is Tivicay. And so really you should look up for every drug that your patient is taking, the possible interactions for every patient and every medication. That's one reason why it's very handy to have that AIDS Info app on your smartphone. I told you I've been doing this for 33 years, and a day in clinic doesn't go by when I don't look up the guideline to check some drug interaction that I don't remember or a combination that I haven't run into before. So this is very important. What do these things cost? In the U.S., the sticker price of most of these regimens is $3,000 a month or more. Like buying a car, almost no one is paying the sticker price. But these are the average wholesale prices as listed in July in the DHHS guidelines. You'll see Triamec is the least expensive, and Genvoya, the other single tablet regimen, is close to that. So these are the two that are competing with each other as single tablet regimens. You'll see the boosted protease regimens in the bottom box are much more expensive, $3,500, close to $4,000 a month as the sticker price. Just to show you, I made up a regimen which used to be considered good. We would now consider it not a reliable regimen, but zidovudine or Retrovir with 3-TC or lamivudine and nevirapine or Viramune. These three are all generics currently in the U.S., and they would be $1,500 a month. We don't know what the future holds for formularies as more and more medications become generic. Right now, the only generic combinations you can put together are not really recommended regimens, but soon there will be generic options for the recommended regimens, although not necessarily in combination pills. And we'll have to see if formularies allow you to continue to use the more simple combination tablets, or if you'll have to prescribe individual components to try to save the money on the generics. We'll just have to see how that evolves. There's a big push among HIV treaters to try to maintain the combination pills on formularies because they're so much easier, because adherence is better, and because a patient can't accidentally take a partial regimen. They have to take a full regimen, which reduces the chance of drug resistance. So for successful treatment, you need a patient commitment to lifelong treatment without interruption. I tell people you have to take this every day until there's a cure. The patient has to be committed to working with the treatment team to achieve success. So when anything goes wrong, they have to call you or call their case manager to deal with any barrier that turns up along the way in the years of treatment. There has to be a payment mechanism for medications. Most people are not paying out of pocket $3,000 a month for these medicines, so there has to be a way of paying for them. In Michigan, we are lucky because we have expanded Medicaid, Healthy Michigan, which pays for all the antiretroviral therapy, all of the Medicaid managed care plans. They're meant to have the same formulary with a carve-out, so all the antiretrovirals are covered, but I will tell you that they're not all on every formulary, so sometimes you have to argue a bit with the managed care plan till they find out that, in fact, the state of Michigan will pay for a newly licensed but approved antiretroviral drug that hasn't made it on that managed care plan's formulary, but is still covered as part of the carve-out. It's extra work, but can be done. We need to pay for the laboratory tests. We do thousands of dollars of laboratory tests, and of course, people have to pay for the appointments. So there needs to be payment mechanisms for these things, or perhaps you're in a site with Ryan White funding that will cover some of these costs. In Michigan, we also have the Michigan Drug Assistance Program for uninsured people who are not eligible for Medicaid. This covers essentially all the licensed antiretrovirals and other medications as well. In Michigan, I have never had someone who wants antiretroviral therapy who is willing to work the bureaucracy who is unable to get medicine. So we are very lucky in our state to have a great MIDAP program and expanded Medicaid. You might have to address mental health and substance use disorders or get help with them for a person to have consistent, excellent adherence for years at a time. And patients usually need support systems to accomplish this. They need their partner to help, their family to help, their friends to help, you as part of the treatment team, and often they will need HIV case management to help them with health insurance and other issues, MIDAP, Healthy Michigan, Affordable Care Act enrollment, and this should be available from your local HIV service organization or from your local health department. This is a list of the minimum baseline data for starting medications, a viral load, a CD4 count, an HIV genotype. The standard genotype is for the reverse transcriptase and protease genes. We are often doing integrase genotypes too in someone with very recently acquired HIV, although the published standard says you don't have to do an integrase genotype yet on everybody because there's not very much transmitted integrase drug resistance nationwide so far. The state of Michigan is monitoring this closely. You need to know the hepatitis B surface antigen because you need to know if you're treating hepatitis B or not. I showed you the differences between some of the regimens that are effective or dangerous in the setting of hepatitis B. For safety's sake, you need the CBC, the creatinine, liver function tests. If you're thinking of abacavir, you need the HLA B5701, and remember it's B5701, not some other HLA marker. You want to know the pregnancy status because that might affect your choice of medicines and how quickly you act. And then there's other desirable baseline data that's really for primary care of people with HIV and is discussed in the other presentation. Hepatitis serologies, STD testing, tuberculosis testing, toxoplasma antibody testing. You want to know lipids. You want to screen for diabetes. We want to know a general urine analysis, and we want to look for subtle protein leaks in the kidney with the microalbumin creatinine ratio. Once somebody is on treatment, we do routine follow-up. We monitor the HIV RNA pretty frequently at first. When someone starts or changes treatment, you have to get a viral load within usually 1 month. The guideline says 2 to 8 weeks. 1 month is kind of convenient. When the person is finishing their first bottle of meds, you get them back in to see how they're doing. You want to make sure they're taking the medicine, that they're not having serious side effects, that they even actually fill the prescription, and you're looking to see what level of viremia they have. With integrase strand transfer inhibitors, they may already have achieved an undetectable viral load in the first month. With a protease inhibitor, it might take several months to get that low. For most of the licensed tests currently, they measure down to a level of 20 or 40 or 50 or 75. These are called the lower limit of detection, or LLOD, and we're hoping to get patients' viral loads down below those numbers, less than 20 to less than 75. We call that undetectable. Even if the test result says detected but less than 20, says less than 20, we call it undetectable. Once someone achieves that, after a series of tests, and they're stable on a regimen with an undetectable viral load, we should be testing them every 3 to 4 months for 2 years. And then if they remain undetectable on the regimen for 2 years, then we drop down to monitoring viral loads every 6 months. If they never achieve full suppression, we see them more often because they're at higher risk of drug resistance and of things going wrong. The CD4 count is very important for many reasons, but is less important as a marker of effective antiretroviral therapy. We still get it at baseline. We use it to decide about opportunistic infection prophylaxis, when to start, when to stop, about when vaccines might be given. And we do expect the CD4 count to improve rapidly at first and then gradually on effective antiretroviral therapy. So we get the CD4 count at baseline. Once someone's on treatment, we will also get it usually every 3 months when they first start treatment. Then as they stabilize on it, it might be every 3 to 6 months. The guidelines say you don't have to keep doing frequent CD4 counts when someone is well controlled. So if they have 2 years of a viral load below the lower limit of detection and their CD4 count is high and stable, you can reduce the frequency of CD4 counts and save some money. So if the CD4 count is 300 to 500, they recommend the CD4 count once a year. And if the CD4 count has gone above 500 with 2 years of viral suppression, they say you never have to measure the CD4 count again unless there's some clinical change or a gap in treatment. This saves a little time in your visits because the CD4 count varies so much with every measurement. 5 minutes of every visit is reassuring the patient that the up and down of the CD4 count is safe. So when we don't measure it, we may save a little time as well as a little money. But that's only after the person has been stabilized for 2 years on antiretrovirals and when they've achieved a safe CD4 count. We have some definitions of failure. Virologic failure and immunologic failure. So virologic suppression is called when the viral load is less than that lower limit of detection, less than 20 or less than 50 or less than 75, depending on the test your laboratory uses. Virologic failure is always called a viral load repeatedly over 200 in someone on treatment. Other maintaining viral suppression, there is nothing that is known that can help immunologic failure. If the CD4 count doesn't improve, there's really no specific intervention for that except keeping the virus suppressed. Changing antivirals doesn't help unless that improves viral suppression. There's no vitamin or drug or over-the-counter or internet product that improves the CD4 count. You just got to keep the virus down and help the person be as healthy as possible. But when there's virologic failure, you have to consider if they have issues with access to medicines. Have they had a gap in pharmacy coverage? Are they filling their prescriptions? Are they getting them before they run out of last month's? Are they getting next month's supply? Are there behavioral issues in medication adherence? Are there comorbidities like mental health or substance use that are affecting adherence? Are there drug or food interactions? Too many pills? Hard for the person to keep track of all of their medicines, your HIV medicines and others. So there might be a lot of reasons that a person is missing enough to have a virologic failure. But of course, the most challenging part is if due to any of those reasons they've missed them enough medication to develop drug resistance, then the same regimen isn't going to work and we have to find something different. So we test for drug resistance, of course, at baseline, and then again, if somebody is not virally suppressed, the usual test is an HIV genotype. It sequences part of the HIV genome to look for specific mutations in the reverse transcriptase gene, the protease gene, and in special testing, the integrase gene to identify the mutations that are associated with drug resistance. Remember, for most labs, the integrase resistance test is a separate test that you order, distinct from the standard HIV genotype. There is an HIV phenotype test, which is more like the drug resistance test you do on bacteria, but fancier technology. It takes weeks, much longer to run than a genotype, and it actually grows the patient's virus in different concentrations of antiretrovirals. So in some ways it might be more accurate, but it's actually still hard to interpret. It's much more expensive and takes longer to get. So we really only use that if someone has failed a few regimens and we're trying to figure out especially what protease inhibitors are still active when it's challenging to figure that out on a genotype. So the genotype resistance testing is recommended at diagnosis. It's recommended prior to starting antiretrovirals if there's been a time delay between the initial diagnosis and time you're starting treatment, and if there's virologic failure. So these tests usually require a viral load of at least 1,000 to be reliable. Our hospital lab doesn't like to even try to run the test if the viral load is under 1,000. It might work if the viral load is over 500 and you can negotiate with your lab to try to run it, but you may not get a result at lower viral loads. Certainly viral loads of 200, they usually don't work. So we don't usually recommend this genotype resistance testing in people who have been off medicines for more than a month because you can miss mutations. Viral strains with certain resistance mutations may become infrequent if the person has stopped medication and that viral mutation turns into a deficit to the virus because it makes it not grow as well, rather than an advantage because it's protecting the virus in the presence of medication. And mutations that are present in less than 20% of circulating virus are not detected by the current clinical genotype tests. So it's very easy to miss mutations. And so a genotype test is true, but it may not tell you the whole truth, especially if someone has been off medication or has had different regimens over time. So when you have drug resistance, unless you're already quite experienced, it's good to get expert advice. There's extensive cross-resistance among classes. You have to review the entire antiretroviral treatment history and all the prior resistance tests, because a resistance that was detected a few years ago is still important today, but the genotype test might miss it. You have to select a regimen with at least 2 and preferably 3 active drugs, hopefully at least 1 potent drug, hopefully from a new class, if you can find that. You have to look for all the drug interactions, and still you want to minimize toxicity and maximize convenience. And that's why getting expert advice is usually helpful when you have to come up with second and third line regimens. When someone has changed regimens, often what they have to take is more complicated than the regimen that they took before, on which they got drug resistance. So someone who didn't manage 1 pill a day is now taking 2 or 3 pills twice a day. So adherence support is extremely crucial in this circumstance. And you have to closely monitor their virologic response on a new regimen to be sure you achieve virologic control. As I mentioned at the beginning, use of antiretroviral treatment in this way to control the viremia of patients who are infected is very beneficial, not just for the person's own health, but as a prevention intervention. So we call treatment of HIV-infected persons as prevention, TASP, treatment as prevention, because as their viral load comes down below 1,000 and to undetectable levels, the chance that they will transmit, especially through sexual exposures, becomes very, very small. This is an important intervention that can really change the future of the epidemic, and this will be discussed somewhat more in the accompanying slide set on primary care of HIV persons. Other uses of antiretrovirals for prevention is PrEP, pre-exposure prophylaxis, for persons who are not infected but are at risk of acquiring HIV. You can use licensed FDA-approved medications for this purpose. That's reimbursed by payers. There's also post-exposure prophylaxis for uninfected persons after a possible recent exposure. This idea started years ago with protecting healthcare workers after a needle stick exposure from an HIV-infected patient, and is now expanded to include non-occupational exposures, including sexual assault and other circumstances. And finally, use of antiretroviral therapy is extremely effective in preventing transmission from mothers to their infants by preventing perinatal transmission. And this was alluded to in the slide describing antiretroviral treatment regimens to be used during pregnancy. There's elements of TASP and PrEP and PEP in that whole package of preventing perinatal transmission. So the use of antivirals for prevention is discussed more fully in the companion video presentation, Primary Care of Adults with HIV, also on this website. So to wrap up, we mean to integrate HIV care and prevention to really change the future of the epidemic in our state and across the United States. It starts with routine testing of youth and adults. The companion slide set describes more about HIV testing. Routine testing at least twice during pregnancy, at the diagnosis of pregnancy and in the 3rd trimester, and the 3rd test in pregnancy for women who are high risk or have missed the first 2 opportunities. For HIV-infected patients, we mean to provide effective antiretroviral therapy for their own health and for the protection of partners. This can involve linkage and retention and care and adherence support for viral suppression among those treated persons, and of course involves management of comorbidities and health risks. And we will talk more about the comorbidities, primary care in the accompanying slide set. We mentioned in passing PEP, or post-exposure prophylaxis, both in occupational and NPEP non-occupational settings. And we mentioned the use of PrEP, pre-exposure prophylaxis, to prevent acquisition of HIV. And both of these interventions will be discussed more fully, also in the accompanying slide set. We hope that the future holds protective vaccines, therapeutic vaccines, and successful research on a cure. But until then, we have very strong interventions to really protect our patients and change the future of the epidemic. So in 2016, remember, everyone with HIV should be treated for their own health and to reduce transmission. That the DHHS guidelines recommend 9 effective, safe, well-tolerated options for initial HIV treatment of persons who do not have any drug resistance, and that additional regimens are available for use during pregnancy and for other special situations. And we encourage clinicians in Michigan who are interested in doing antiretroviral therapy to join in this intervention, to educate themselves to be able to use antiretrovirals effectively and safely. To help persons who are new to treatment along in that path, MDHHS has several options for you. There's expert consultation for Michigan providers through the Michigan HIV Consultation Program, newly developed at Henry Ford Hospital. They have a great website on which you can access many, many guidelines and also pose your questions that will be returned within 1 or 2 business days. And they have an urgent helpline for 24-hour questions for urgent situations, such as a PEP event that an exposure that might require PEP, or recently diagnosed pregnancy where there's some urgency in getting the person into care. We also at Maytech Michigan can help you by emailing Forsyth@sunsciencewayn.edu. We can answer your questions in 1 or 2 business days, and we also have a phone line for urgent questions. As I mentioned, the DHHS guidelines themselves, as a living document updated every few months, is online at aidsinfo.nih.gov, and the app with the guidelines is available there, and that also updates automatically. So I'd like to thank the Michigan Department of Health and Human Services for providing the opportunity to give you this information, which I hope will facilitate your diagnosing and treating HIV patients and helping us address this situation across our state. Thank you.